Hi everyone, the webinar will begin in just a few moments. Welcome everyone to today's Research Roundtable on epilepsy in childhood. There are approximately 112,000 children and young people living with epilepsy in the UK, so it comes as no surprise that epilepsy in childhood is one of our most requested webinar topics. Today we have a brilliant lineup of speakers. We'll firstly hear from Epilepsy Research UK supporter Hannah, a student at Circus School who will be discussing the impact that epilepsy has had on her life and during her childhood. We'll then hear from Dr. Jo Simmons, a paediatrician at NHS Greater Glasgow and Clyde and honorary clinical lecturer at the University of Glasgow, who was awarded funding from Epilepsy Research UK in 2013 to investigate the genetic and autoimmune causes of epilepsy. And finally, we will hear from Dr. Tim Tierney, who was last year awarded the Epilepsy Research UK and Young Epilepsy Fellowship Award to develop bedside brain imaging. All of today's speakers have contributed to our research blog this month, so if you're interested in hearing more, we'll be sharing the link to the blog in the chat. Just before we hear from our speakers, have you ever wondered why research on an area of epilepsy that affects you has not been a priority? Have you ever wondered how you could draw attention to this? And have you ever wondered how your opinion could make a difference? Well, if any of those questions have occurred to you, or even if they haven't, we want to hear from you. Earlier this month, we launched the UK Epilepsy Priority Setting Partnership, a landmark national survey that will collate the views of the entire UK epilepsy community. We're seeking the input of all those working in epilepsy and all those affected by epilepsy, including families, carers, and friends. Epilepsy affects everyone differently, and we want to know what you consider to be the top priorities for research into epilepsy. This is a unique opportunity for you to have your say in driving and shaping the future of research. So for more information and to complete the survey, visit the link on screen now. So back to the webinar. I would now like to introduce our first speaker, Hannah. Welcome, Hannah.
Hi.
Hi, how are you today?
I'm okay, yeah.
Brilliant, thank you. Well, today you're going to be speaking about your experiences of epilepsy. So thank you so much for taking the time to speak with us today. So first of all, how has epilepsy interrupted your life and your childhood?
I think it's definitely affected me in ways that I didn't realize that it had, but I've definitely noticed in the last sort of year or so that it's had quite an effect on things like my anxiety. I think I have this need to have everything planned out and for a lot and know exactly what I'm doing and when. And at first I was like, oh no, I'm just a bit of a control freak, it's fine. But I actually think because epilepsy for so long had such an impact on my life where they couldn't find the right medication to control my seizures, I think it's really affected me in the sense that I now like to have everything planned out in case something happens. And even though my epilepsy is controlled now and it doesn't have an effect on my life, it's completely changed how I like to have things done. And it's really, yeah.
Gosh, so it's completely determined how you approach your everyday routine, really.
Yeah, sure.
Yeah, and you mentioned in your blog that you were diagnosed with epilepsy when you were 4 years old. It must have been,
yeah.
That's such a young age, isn't it?
Yeah, I think it's it's always for a long time been part of me. So I kind of think I've got to a point now where I'm quite comfortable talking about it. So I think having it at such a young age in some ways has been a really positive thing because I've kind of never really known any different. But also I was definitely quite it affected my childhood because I was always very cautious on what I was doing. I never I would be worried to go out and just do something because I'd be worried about something happening with my epilepsy. And I think a lot of, yeah, like sleepovers and things, I never wanted to do those because I was worried I was going to have a seizure, unless I like knew the person really well. So,
of course. And you also mentioned in your blog about finding a support group and the help that this was.
It definitely helped me deal with the anxiety I had around epilepsy at the time, and like that feeling like when you're like 14, you want nothing more than to just fit in and be like normal. And I think it definitely helped me accept that it's okay to be a little bit different, and it's it definitely helped me realize that actually my anxiety around epilepsy was completely valid, but my epilepsy also didn't define me. And I think that was a bit, once I had that realization, it made it a lot easier for me to talk to people about how I had epilepsy.
Of course. And we mentioned that you're currently studying circus performance and acrobatics. This sounds so exciting. How did you become interested in this?
I used to dance when I was younger, but I didn't like the culture of dance because it's not the best sometimes. And I had a friend that was in the youth circus in Newcastle, and I went and tried it out, and I really liked it because it was a bit more, you had a bit more freedom than you do in dance, but it still had the same sort of aspects of it.
And has your epilepsy affected your ability to perform?
I don't think it has. No, like I'm very lucky in that I don't have photosensitive epilepsy, so I'm able to perform in that sort of all that kind of stuff, and particularly with it now being controlled, I can go and I can train and perform and it doesn't affect me at all. But I actually recently, one of our projects we had to do at university was a stand-up piece including circus, a stand-up comedy piece including circus.
Wow.
I did mine about my epilepsy because I was like, it's such a big part of me. So it's nice because I've got to a point with my epilepsy where I can make jokes about it, and I'm comfortable doing that, and like me and all my classmates can have a bit of a laugh about it, and we're super comfortable. But it hasn't had an effect on my performance in the sense that I haven't been able to perform, which is really, really lovely.
Brilliant. So it hasn't held you back at all, really. Brilliant. And what would you say to anyone who's newly diagnosed or has a family member who's newly diagnosed? What would you say to them?
Yeah, be open about it and accept it, because it's not going to change. And like, it sounds harsh, but there's no point in sitting there and like sort of like just sitting there and thinking about something that you have no control over and you can't change. And once you have the right medication, even if it's a medication, like I'm on sodium valproate, I have to sign the thing for it every year. But like, even if that medication is like sodium valproate and has an effect on could have an effect on other parts of your life, it's so important to like, once you found that medication, stick with it, and once it's controlled, not let anything hold you back, because epilepsy is a part of you, but it's not all of you, like I said in my interview. Like,
I think that's such a positive note to leave things on, and you've demonstrated through your circus and acrobatics that although it is a part of you, it certainly hasn't defined you. So thank you so much, Hannah. And we'll be coming back to you after we've heard from our other speakers with some questions. But a huge thank you, Hannah, for speaking about your experiences of epilepsy.
Thank you.
So now I would like to hand over to Dr. Joe Simmons, who will discuss his research investigating genetic and autoimmune causes of epilepsy. So over to you, Joe.
Thank you, Quiba, for the introduction. So I'd just like to tell you a little bit about this study that our group was awarded a project grant for back in 2013, and it was called the Genetic and Autoimmune Childhood Epilepsy Study. And we continue to look at this project actually and learn more about it every year. So I'm based at the Royal Hospital for Children in Glasgow and the University of Glasgow as well. So the reason why we did this study is because we recognized that epilepsy that begins in early childhood is more common than epilepsy at other ages. So this is a graph showing how frequently people present with epilepsy. And over here on the left, we have very young people up to the age of 4. And then the incidence of epilepsy drops down as you get a little older and then rises again as you move into the 60s and 70s and beyond. But we know that epilepsy that begins in early life is often associated with seizures that are hard to treat with medications, and also associated with developmental problems. So that can lead to learning disability later on. And we can now appreciate that these two things, the epilepsy control and the developmental problems, exist on a sort of axis. So some people have neither difficult to treat epilepsies nor difficulties with development, and some people have either one or the other, and some people have both. What we've learned over the last few years is that we can find causes of epilepsy with increasing frequency, particularly in those whose epilepsy begins early in life. So one study found that almost a third of under 3-year-olds had a cause for their epilepsy found. So it's not just enough to say what your epilepsy is, what kind of epilepsy is. We need to find a cause if we possibly can. And why is it useful to find a cause? Well, we know from previous studies that finding a cause gives families accurate information about what it is that they have. And sometimes if you find a rare genetic cause, families can connect with other families, often over the internet, who have the same rare disorder. In a study that our own group did, looking at a particular genetic type of epilepsy called SCN1A, we found that in a huge proportion of these children, knowing this genetic cause actually gave doctors information about which medications to avoid. Families can find it helpful to know what a genetic cause is in order to predict whether it's going to affect another child, maybe one that's not yet born. And finding a genetic cause can stop you from doing further tests, which might be costly or invasive. So lots of other studies in the past had looked at how useful it was to do genetic testing. But the problem with these studies was that they had variable inclusion criteria. So some of them might include only children with very bad or difficult to control epilepsy. Some of them might only include children with a particular type of epilepsy, such as infantile spasm syndrome. So what we wanted to do was just see how useful it was to do genetic testing in children overall, all under 3-year-olds. And we also wanted to look at autoimmune causes of epilepsy, because we know from previous research that a proportion of children with epilepsy, nearly 10% in this previous study from the Netherlands, will have antibodies to parts of the nervous system. So these are little proteins that the body makes thinking it's fighting infection, but are actually directed against parts of the brain. And that can be associated with seizures. So our questions for this study were to find out what proportion of early childhood onset epilepsies, we can find a genetic or an autoimmune cause, and how often does knowing this cause give us useful information about how to manage that epilepsy. So we did this by prospectively recruiting all children presenting with epilepsy and also certain complex fever-associated seizures over a 3-year period. And we involved every single centre in Scotland. And we followed up these children to see what kind of epilepsy they had and whether they had any developmental disorder associated with it. And we aimed to recruit 300 children, so 100 per year over the 3 years. And we included all children with a new diagnosis of epilepsy, all with a prolonged seizure, so half an hour, a seizure lasting half an hour or longer, whether that was associated with a fever or not, and children who had 2 or more seizures within a 24-hour period. We also included children who had 2 seizures associated with fever that lasted 10 minutes or longer, and children who presented in the really early newborn period and continued to have seizures beyond the first month of life. And we put posters up all over Scotland, inviting people to recruit children to this study. And we reminded people a lot throughout the study by sending emails, reminding people in epilepsy specialist nurses and in the intensive care units and general pediatricians as well to recruit all the children they could to the study. So what did we find? So in total, over the 3 years, we recruited 343 children with seizures. So that's a little bit more than what we expected. Of these, 240 actually had a diagnosis of epilepsy made. So that made the incidence of epilepsy in the first 3 years of life 250 per 100,000. So that's 1 in 400 children will be diagnosed with epilepsy before their 3rd birthday. So that's 1 in 400 children, which looks like this. And the first paper that we produced from this data was describing the genetic causes of epilepsy in this cohort. And this was published in the journal Brain in 2019. And what did we show in that paper? We found that 24% of under 3-year-olds have a genetic cause found. So that is equivalent to 1 in 2,000 children born will have a genetic form of epilepsy. So 1 in 400 will have epilepsy and 1 in 2,000 will have a genetic epilepsy. We found that you're more likely to have a genetic diagnosis if your seizures began early in life, particularly in the first 6 months, if your seizures were either focal seizures or infantile spasms, if you had developmental delay associated with your epilepsy, or if your seizures were difficult to treat with medication. Really importantly, we found that 80% of all the genetic diagnoses we made had implications for treatment choice. So they might say, well, because you've got this genetic diagnosis, we should avoid this medication or we should choose this medication. And we found that certain genetic diagnoses had clear patterns to presentation. So these are the most commonly implicated genes. So there were lots of genes associated with epilepsy, but some of them were much more common than others. And I've shaded in black the ones where there's clear evidence for a specific choice of treatment, and in gray the ones where there is less strong evidence, but evidence there nonetheless. And overall, this was 84% of the genetic diagnoses would inform treatment. And this is just being able to look in detail at the most commonly associated genes and how common they are going to be among the general population. So the most frequent gene was something called PRRT2, and this affects just more than 1 in 10,000 children. And this represents the age at presentation depending on the gene. So the very early onset epilepsies, those that present in the first 3 months of life, are much more likely to be to do with this gene, a potassium channel gene, KCNQ2. And then these next 2 genes take over, SCN1A and PRRT2, with both of those peaking at around about 6 months of age. What about the autoimmune findings? Well, this was slightly more confusing. We found that 6% of the under 3-year-olds had these antibodies against their nervous system, but we didn't find that there were any differences between those that had antibodies and those that didn't. So not in terms of how old they were when they presented, what kinds of seizures they had, how easy to control the seizures it was. So we're left a little bit stumped as to whether these are significant or not. There's a paper on this published in the journal Neurology in 2020. And what's important to notice is that the proportion of children that had these antibodies, apart from one antibody, this GABA B antibody, was very similar to what you would expect in the general population. So there's an open question about whether this GABA B antibody is significant, but we think the other ones that we looked at were probably not. So in conclusion, 1 in 400 children will be diagnosed with epilepsy before they turn 3. And almost a quarter of those you can find a genetic cause. And of the genetic causes, more than 80% have implications for treatment choice. We do find antibodies in these people, but we're not sure how significant they are. And I'd like to thank all the different people that are involved recruiting and following up these children. And as I say, we continue to follow them up, and we will continue to produce more papers and disseminate more data from this study. So if anybody has any specific questions for me, that's my email address and that's my Twitter tag. Thank you very much.
Brilliant. Thank you so much, Joe. That was really fascinating to hear about this work. And although it was funded in 2013, it's still having big impact for children and young people with epilepsy now, isn't it?
Yeah, so I mean, we've been very lucky in that we've been able to continue to follow up these children, and it's been an area of childhood epilepsy research that really seems to have gathered the interest of clinicians, because I think a lot of them really are interested in how useful it is to do certain tests, because when they've got a patient in clinic, they want to know what it is they should be doing. So I've been really privileged to be able to present this data all over the world, mainly on video meetings over the last couple of years. But yeah, it's been great.
Of course, and it was really staggering to learn that 80% of the genetic diagnoses that you found had implications for the treatment choice. That's a staggering proportion of cases, isn't it?
Yeah, and I think, to be honest, what's more exciting is what the future means there, because a lot of these genetic epilepsies are potential treatment targets for new treatments. So the genes often are genes that code for important parts of your brain function, often at the place called the synapse, where two nerve cells meet. And if we can target treatments that are specifically designed to fix whatever machinery is broken because of the genetic change, we might be able to do more than just control seizures, but also improve what we call the comorbidities, the other problems that young people with early onset epilepsy experience.
And do you think, Joe, that obviously you conducted genetic testing on all children under the age of 3, but do you think that will become a part of routine practice for children with epilepsy, that they'll have genetic testing?
Yeah, so I think this is what is actually happening, is right now in clinics, people are thinking, should I do genetic testing? And so it's a very, very relevant question that we've answered, because it's relatively easy to do a genetic test nowadays. You take a blood sample from a child, often you take it from their parents as well, in order to interpret the findings. And the next question really is, what do you do with that genetic sample? Because there are so many different types of testing you can do. And at the moment, as the technology gets more and more advanced, we're doing greater and greater amounts of genes that we're able to test for. But one of the things that I want to really make the point about is that just because the technology is getting cleverer, and we've got to make sure that we don't become less clever about how we do genetic testing, because it's all very well testing for everything at once, but if you're not sure how to interpret what you find, then it might lead to more confusion than benefit. So I think the research we've been doing to show what you expect the epilepsy type to be with a particular genetic finding is really important.
Brilliant. Well, thank you so much, Joe, for sharing this work with us. It's been so interesting to hear about it, and we'll be coming back to you at the end of the webinar with some more questions, but a huge thank you for now, Joe.
Thank you, Kriva.
And now I would like to hand over to Dr. Tim Tierney, who last year was awarded the Epilepsy Research UK and Young Epilepsy Fellowship Award to investigate bedside brain imaging. So welcome, Tim.
Hi, everybody. Let me just get up my slides. Okay, I'm delighted to be talking today about my project, Bedside Brain Imaging. But before I get into the nitty-gritty details of the brain imaging, I want to talk a little bit about the background to this technology. So the first question I often ask people is, did you know that your brain is magnetic? Not a lot of people do. But if you were to zoom in on the brain, you would see it was composed of millions and millions of cells called neurons, which communicate using electrical currents. Now, every time you have an electrical current in a wire, it's surrounded by a magnetic field. A magnetic field is also produced, and we can measure that magnetic field with specialist technology. That technology is called magnetoencephalography, or MEG for short. And traditional systems look a little something like this, like the one I have on the left. And immediately what you should be able to see is that this system is about, it's quite large, it's 1/2 ton in weight, but it can measure these magnetic fields produced by your brain. And the relevance to epilepsy and pediatric epilepsy is that if you were to have a seizure, that seizure would produce a characteristic magnetic field. So as an example here on the right, I have a picture of a brain and the magnetic field produced by a very particular brain region. Now, if a different brain region was acted, or if the seizure was coming from a different brain region, it would produce a very different magnetic field, like this, or from a different brain region again, like this. And while this technology has been quite useful in helping us to plan brain surgery for adults with epilepsy, there's a little bit of a problem with the current measurement system. And that's that the imaging success often declines the younger a person is. So you can see that, at age 5, you have 50–60% chance of getting successful imaging. And as we've already heard, there are so many epilepsies that have early onset in childhood. It's really important that we have good imaging for children in this age group. And the reason that the imaging fails is because if you put a child inside a brain scanner, they tend not to want to keep still. They move about a lot. And unfortunately, we need children to keep as still as possible if we want to get good quality brain imaging data. So over the last number of years, I've been working on technology that will allow us to measure brain activity even while someone was moving around. So as a quick overview of the evolution of this technology, before 2016, we were working with these very large half-ton machines. Then between 2016 and 2018, we developed a prototype system, which looks admittedly quite sci-fi, but it was a huge step change in terms of making just a helmet that could be worn while measuring brain activity. At the moment, we have working with helmets that look a little bit more like this, and which are more streamlined. And each of these little black boxes on the person's head is one of these sensors and does the exact same job as this same half-ton machine. So we've gone from half a ton down to half a kilo, which is quite a step change. And this allows us to image brain activity even while someone is moving around, which is perfect for working with young children. So as an example of some of the early pilot studies we've been working on with young children, I just thought I would share you some photos of some of our initial tests. The first one simply involved drilling holes into bike helmets and sticking our sensors in there. But we moved on progressively to develop 3D printed helmets, which have been quite successful in some of our pediatric studies so far. Now, what I'm working on right now is the step of how we bring this technology from the lab into the clinic. So what you may not know is at Young Epilepsy, a charity for young people with epilepsy, they have recently installed one of these lightweight MEG systems. And my role at the moment, as one part of my fellowship funded by ERUK, is to help set up the kind of phase 1 clinical trials here, where we see how do children tolerate this new brain imaging system, but also does it tell us the correct information? Does it do what it's supposed to do? And moving a little bit forward, we're looking to secure funding for phase 2 clinical trials, where we see exactly what extra information this adds clinically, how does it compare to other brain imaging technologies, and so on and so forth. But all this aside, there are still problems with the technology. The big one is whether you have one of these heavier systems or one of the lightweight systems, they both require something called a magnetically shielded room. And what these rooms are is essentially they're big rooms like bank vaults, which block out magnetic fields from passing trains or cars or laptops. Anything metal or electronic will produce an interfering field. And we want to remove all that so we can just focus on measuring the brain activity. But these rooms are big, heavy, and expensive. So down the line, my project with ERUK will be about how we can take this technology and bring it straight to the bedside. And how we're going to do that in this little schematic here is an example of a child in the bed with a little helmet on, having a brain scanned. And either side of the child, there are these panels. Now, what these panels are electromagnetic coils that minimize the electromagnetic interference around the child so we can just focus on the brain activity. And while that may sound complicated, it's really the exact same process as noise cancelling headphones, where you can remove the noise from the outside world just so you can focus on the music, or in this case, the brain activity. So if I was to wrap up a little summary of what I've just talked to you about, we can use magnetic fields to help plan brain surgery for young people with epilepsy. So we can do this in a way tailored for a pediatric environment. And hopefully in the future, we'll be able to do this at the bedside. So thank you all very much.
Thank you so much, Tim. That was so brilliant to hear about this exciting research. And it's amazing to hear that we've gone from the machine weighing half a ton to what looks like a much more sophisticated bike helmet weighing half a kilo. That must be well, it's a huge difference, isn't it?
It's absolutely tremendous, and it's a complete game changer in who we can scan. It means that we're much more able to scan young kids who, as I said, don't want to keep still. And again, this is such a crucial age group that we get good quality brain imaging data early, so we can help get them the right treatment as soon as possible.
Brilliant. And do you think that one day it could be that the bedside brain imaging, that it's available in all clinical settings, or maybe even in the home setting? Is that kind of the long-term plan?
So I think there are two ways to look at it. You could have specialist centers that have the traditionally big, heavy, magnetically shielded rooms, but then also maybe a more lightweight system, as you said, in every hospital as a frontline tool. But that's going to require an awful lot of work moving forward. But one kind of brilliant advantage of it is that it requires no setup time. Now, in frontline neurophysiology, you have to prepare an EEG cap, which may take up to an hour, depending on how many electrodes you have to place. And many children find this very, very uncomfortable. But with this system, you can just plop it on the head and you're ready to go immediately. So it could have huge impact in the clinic in terms of streamlining things.
Wow, so it could even speed up the diagnostic process and
exactly.
reduce waiting times too. Gosh. Well, thank you so much, Tim, for sharing this work. And we're so excited. It begins in the new year, doesn't it?
Yes. Although, as I said, we're getting ready, ramped up to start our trials as soon as possible. So yeah.
Fantastic. So we can't wait to hear how this research develops. And for now, I'd like to bring Hannah and Joe back in. We've had some brilliant questions that have been submitted ahead of the webinar that we'd like to ask our panelists today. And so Hannah, I'd like to start with you. One question that we ask members of our SHAPE network is, what one thing would be life-changing for you in terms of your epilepsy?
I think maybe finding like a medication that doesn't require the stress that sodium valproate kind of puts on me a bit. You can't really take it while you're pregnant and stuff. And I'm 19. I'm not thinking about having a child at this point in my life, but it would be nice to find a medication that I don't have to think about that so much. And then also finding the cause of my epilepsy as well, because I still don't know that and I would like to know that.
Of course. And Joe, I wonder, is this similar to things that you hear in the clinic from patients, that they'd like to understand the cause of their epilepsy more?
Absolutely. So I think it's understandable so for Hannah and for the children that are in my study, it's the parents that are asking questions at the beginning, because they're the ones who are bringing their child to the clinic, and in the under 3-year-olds, obviously a lot of them can speak, but they probably don't understand a huge amount about epilepsy and diagnostics at that stage. So the parents are asking questions, and I think it's understandable when you're going through this really unexpected and frightening time. Your child's having these seizures, not something that you were expecting to happen or you foresaw as a scenario. And the question you're going to ask is, why is this happening? And traditionally, as neurologists, as epilepsy specialists, we've tried to answer those questions by doing tests like EEGs, so brainwave tests to measure the electrical activity. But that's limited in what information it can give us. It can tell us, it can support our diagnosis of epilepsy, and it can help us what we call classify the epilepsy. So we might be able to say that this is an absence epilepsy or a focal epilepsy, but it still doesn't answer that question that parents have, which is, why is this happening? And that question we ask as clinicians, so then we do a few tests, and maybe those tests don't give us the answer, and then we do a few more tests, and maybe those tests don't give us an answer. And these families can end up on a very long and stressful journey, where they could be going for years trying to find out this Y answer. And so if we can give the Y answer as early as we possibly can, I think that's really helpful for families. They can say, oh, well, this is what it is. And they can potentially, in these rare genetic epilepsies, which actually aren't that rare overall, we're talking about a quarter of them, they can connect with other people who are going through the same thing. And they say that's really, really helpful. So in the clinic, we see every week, we have an epilepsy genetic clinic in Glasgow. We see families benefiting from early genetic diagnosis every week. And
Hannah, you were nodding and smiling along there. So perhaps that's something that resonated with you and that your family would have liked to learn as well.
Yeah, I think particularly for like the first 10 years of me having epilepsy and it not being controlled, I think it would have definitely been nice to know why. For sure. Yeah, for like everyone as well, like my parents and for me, particularly as I got older, and definitely resented my older siblings for not having epilepsy and me having it. But yeah.
Of course, that must have been, really, really difficult comparing to the older siblings as well. And I know it's something like 65% of people with epilepsy don't know or there is no known underlying cause of their epilepsy. So this is something that happens quite frequently. And just to go back to the research, so Tim, how long do you think it will be before your research benefits children and young people with epilepsy?
Well, I'm hoping in the short term, so less than 5 years, as these clinical trials progress, we can start incorporating them into routine clinical practice. One kind of very short-term way we can do this is for planning invasive EEG, where they implant electrodes directly into the brain. Sometimes they don't quite know where to put them, but even at this early stage, we can use this technology to help provide a hypothesis so that to guide those procedures. But hopefully, as I said, within the next 5 years, we'll see this Centre at Young Epilepsy up and running and taking kids from all over the country.
Brilliant. Within 5 years is really no time at all. And Joe, the same question for you, your research, how long do you think it will be before it's having an impact on children and young people?
I suppose I've had a bit of a head start on Tim because our project began in 2013. So I think it's fair to say that it actually is now. So what we've shown is that a high proportion of early childhood epilepsies have a genetic cause, and it's worth testing for those genetic causes. And as I say, I've been presenting this data to pediatricians, to neurologists, epilepsy specialists up and down the country and over the world. And I think some of them have been listening, and it's informed what genetic testing strategy they've been doing. So they're involving more children in genetic testing, involving their families, and thinking when they don't find an obvious genetic cause, where do they go next? What more advanced genetic tests can they do? So we are seeing benefits right now from it. I think, as I alluded to in the previous questions at the end of my little talk, I think the future is really exciting in terms of whether there are treatments that can fix some of these genetic errors that are leading to the more severe epilepsies, because we do know that some of the genetic epilepsies can be really tricky to treat and can be associated with a lot of problems. So if there are treatments that target the underlying genetic cause, and there are certainly a lot of companies that are developing these things right now, and those companies are interested in our data because our data tell them how common these conditions are.
That does sound so exciting. And by treatments that can correct the genetics, do you mean things like gene therapies or personalized medicine?
Yeah, so there are lots of different approaches to personalized medicine, but I suppose the most personalized option is something along the lines of gene therapy. And there are different ways that gene therapy can be delivered. And in pediatric neurology, we've seen very recently that gene therapies are being delivered and benefiting children with a neuromuscular condition, something called spinal muscular atrophy, which is a degenerative muscle condition. And there's a gene therapy that we've been giving in Glasgow and other centres are across the world, where you put in using a virus. So viruses aren't all bad, by the way. Using a virus, you insert a correct copy of the faulty gene with a result in improved outcomes. So that's the ultimate in personalized medicine. But there are other approaches where instead of inserting a whole gene, you can give small amounts of nucleic acid. So that's the same sort of thing that makes your DNA. Just to maybe overwrite a small area of a gene that's not functioning quite correctly. So lots of different approaches to this, but most of them hold some promise.
Yeah, really exciting time for research into epilepsy, it sounds. And so, Tim, my next question's for you. Were young people and children with epilepsy involved in your research? And if so, how did this add value to the work?
Yes, they have been from the start. I mean, you got to see a couple of the early adopters in my presentation, but we've also been working with a large cohort of young people with epilepsy to help design our helmets, just to get feedback on what they would like them to look like, feel like, and to basically just optimize them so that they can wear them. And as a concrete example of something we didn't think about was, we were asking about different materials they would like to have on their head. And they were saying they wanted different materials around their ears versus on their scalp. And none of us ever thought about this at all. So that was just a concrete example of something 5-year-olds told us.
Wow, that changed the research for the better as well.
Yes. Yeah.
Brilliant. Young epilepsy researchers in the making there.
Exactly.
And Joe, how about your research? Were children and young people and their families involved in the research?
Yes, absolutely. So one of the things that we do as part of the project is we send questionnaires out to families, asking about the developmental progress of the child, asking about any stresses in their lives, and asking them what they perceive to be the benefits of the testing scheme that we've been using. And we consulted families using the Scottish epilepsy charities before we set up the project. And obviously, as part of the project, we're continually to send questionnaires to families. So I think it's a really important part of making sure that a project is successful when you're involving children, young people, and parents, is that you make sure that the materials you use have been produced in a way that's suitable for them.
Brilliant, thank you. It's great to see people with direct experience of the condition having such input on the research from such an early stage. And so I can't believe it's time for our final question already. And so Hannah, I'd like to turn to you first. What are your hopes for future research into epilepsy?
Jenna, I guess just like more research into the cause of it, and treatments as well, I think would be nice, because I don't know, it's like research into how we can find the cause and then find a treatment rather than having to like try loads of different treatments.
Brilliant, thank you so much, Hannah. And Tim, how about you? What are your hopes for future research into epilepsy?
Well, on a very broad level, more funding, but on a kind of very specific level, more relevant to me, is the kind of brain scanning I do. Even though there's many centres across, let's say, Europe and the world, they all do things a little differently. And I would like, kind of greater international collaboration on the kind of harmonisation of how we approach the diagnostic process.
That's really exciting, isn't it? And I suppose with the world becoming more virtual over the last 18 months, perhaps that international collaboration is becoming more of a reality.
Yes, actually, I mean, it's strange. I have collaborators now who are in, Philadelphia and in Belgium and wherever, and you can just, get on the Zoom call and chat with them, provided the time zones aren't too different. But yeah, it is.
Brilliant. Thanks, Tim. And finally, Joe, what are your hopes for future research into epilepsy?
Well, I think Hannah sort of nailed it there, actually, is that what we want is a situation where we can choose the right treatment as early as possible. So the reality is that the trials that have been done in epilepsy have not been done on a very precision level, so young people and adults with epilepsy are being put into very large groups of whether they have a generalized epilepsy or whether they have a focal epilepsy. And so we don't really have a lot of good data to guide what treatment would be the best. So we want to live in a world where we can choose the treatment that's most likely to work as early as possible. And so my dream is that we continue to do research that will allow us to answer that question. So bringing precision treatments to clinical reality.
And Joe, just to follow on from that, so if we find the precision treatment as at an early stage, will that then have repercussions for the child later in life as well?
Well, that's what we would hope. And there's certainly some very good examples of epilepsies where if they begin very early on and they're involved with a lot of seizures early on, then it can have detrimental impacts on development. And it's not always the case. Some young people and even very young children can have loads and loads of seizures and it doesn't have an impact on their development. So we don't quite understand what that relationship is. But I think one of the things that we can modify is controlling seizures early on. And that's why I want to initially focus my research moving forward onto the group of children that have epilepsy that begins really early in life. So in the first year of life, primarily because this group has a really high rate of being able to identify their cause. And unfortunately, they have a really high rate of having difficult to treat epilepsy and epilepsy that's associated with developmental problems later on. So I think if we can get it right in the very young, then that would be a really good start.
Brilliant. Well, what a positive note to end the webinar on. So thank you so much. A huge thank you to all of our speakers today, to Joe and to Tim for speaking about their research, and a huge thank you to Hannah for speaking about your experiences. I think it was so inspiring to hear that epilepsy, although it's a part of you, it hasn't defined you. So thank you so much. And if you're watching and you're interested to hear more, all of our speakers have contributed to our research blog this month. So do visit the blog and we'll be sharing the link if you're interested to hear more. Many of you may be aware that today is Giving Tuesday, and Giving Tuesday is the day when people everywhere can do something to support the causes that mean so much to them. The exciting research projects you've heard about in today's webinar are only possible thanks to donations from our incredible supporters. So if you enjoyed today's webinar and would like to support life-changing, life-saving research into epilepsy, then why not make a donation? We'll be providing the link to donate in the chat on Zoom and on screen, and to find other ways you can support research, such as making a regular gift or taking part in an event, we'll be sharing the link to our website. So a huge thank you again to all of our speakers, to all of you for watching, to James and Becca behind the scenes for ensuring that the webinar has gone smoothly, and we really look forward to seeing you at the next webinar.